if you look at a classic anatomical drawing, it kind of lies to you.
Oh, absolutely. It's a total fabrication.
Right. Like the textbook illustrations show these perfect, pristine surgical lanes. The arteries are this bright, uniform red. The veins are a brilliant blue. And the nerves are, a distinct, unmissable yellow.
Yeah, a perfect color-coded map.
Exactly. But when you step into an actual operating room, or if you're assessing a trauma patient in the emergency department, you aren't looking at a map. You're looking at a muddy, high-stakes puzzle. Living tissues bleed, they shift, and they hide beneath one another.
And, in the modern surgical era, that puzzle is harder to solve than ever.
Because of the technology we use now.
Yeah, exactly. When a surgeon performs, like a laparoscopic or a minimal access procedure, they're looking through a tiny scope at a monitor. They don't have the luxury of a wide-open anatomical landscape to just, orient themselves.
Right, they're just seeing this tiny zoomed-in patch of tissue.
Right. They are staring at a few square centimeters of magnified monolithic tissue. So if you don't possess a rock-solid three-dimensional understanding of what is lurking just millimeters behind that specific patch of fascia, you are quite literally flying blind.
Which is the exact mission of our deep dive today. Especially for you listeners who are medical students, young professionals, or really just insanely curious minds. We are taking a scalpel to the 12th edition of Last's Anatomy, Regional and Applied, authored by Chummy S. Sinetampi.
It's such a foundational text. Since R.J. Last's first edition back in 1954, the focus has always been on that regional and applied aspect.
Right. It's not just memorizing Latin names. We're going to mentally walk through a trauma assessment today. We're dissecting from the outermost envelope of the skin all the way down to the deepest bone fractures. We want to understand the underlying mechanisms of why things behave the way they do in a living patient.
And to do that, we really have to start where every physical examination starts, the skin.
The biological wrapping paper.
Well, it's tempting to think of it that way, but it's a massive, multi-layered organ system. And to understand its clinical behavior, you really have to look at how it's built from like an embryonic level.
Okay, let's unpack this.
So it has two primary layers, and they have entirely different origins. The surface layer, the epidermis, is ectodermal. That is where you find your specialized appendages.
Like sweat glands and hair.
Yeah, sweat glands, sebaceous glands, hair follicles, and nails. They all originate from that ectodermal layer.
While the layer immediately beneath it, the dermis, is mesodermal in origin, right?
Exactly. That's your structural foundation. It's just packed with dense bundles of collagen, elastic tissue, blood vessels, and nerve fibers.
And before we cut into that dermis, there's this biological mechanism in the epidermis that completely reframes how we think about human pigmentation.
Yeah.
The text highlights that the number of melanocytes, the cells that manufacture pigment, is virtually identical across all human races.
What's fascinating here is that the visual variation in human skin color has, nothing to do with the number of cellular factories.
Right.
It comes down entirely to the output of those factories. In darker skin, those exact same melanocytes simply synthesize a much higher volume of melanin.
Which is then distributed to the surrounding cells.
Exactly. It is a strictly functional difference driven by genetic adaptation to UV exposure, not a numerical anatomical difference.
That's incredible. But when that barrier is compromised, say in a severe thermal injury or a burn, a physician's first priority isn't the cellular makeup, is it?
No, it's total surface area. Fluid loss through compromised skin is lethal. You have to stop the hypovolemic shock.
And this is where the rule of nines becomes a critical algorithm, right? For mapping the body's surface area.
Yeah. It maps the body in multiples of 9 to calculate fluid replacement rapidly. So the head is 9%.
Okay, head is 9.
Each complete upper limb is 9%. The front of the torso, so that's the thorax and abdomen combined, is 18%.
Got it.
The back of the torso is also 18%. And then each complete lower limb is 18%.
Right, because when you have a patient crashing in a trauma bay, you don't have time for complex geometric calculations. You need an immediate, standardized functional assessment to get those IV fluids started.
Exactly. You just do the math and go.
But let's say the trauma requires us to actually open that skin surgically. We have to talk about tension lines. For a long time, surgery relied on Langer's lines, right?
Yeah, which were mapped out by a researcher back in 1861. He basically punctured circular holes in cadavers to see which way the skin pulled.
But a cadaver skin doesn't have the same mechanical tension as a living, moving patient.
Right, a crucial distinction. Cadaveric tissue has completely lost its natural muscular and elastic tone. So modern surgery relies instead on relaxed skin tension lines.
And those are different.
Yeah, they correspond to the subtle fine furs you can see when living skin is entirely relaxed. And they're dictated by the directional arrangement of collagen fibers deep in the dermis.
I picture it kind of like the grain in a piece of solid wood. If a woodworker drags a saw directly across the grain, the wood splinters, right, it leaves a jagged, rough edge.
That's a great analogy.
But if you cut parallel with the grain, the blade glides smoothly. So when a surgeon aligns their scalpel with those relaxed skin tension lines, the wound edges naturally sit flush against each other without mechanical pulling.
And that lack of mechanical tension is exactly what prevents a massive fibrotic response. It heals with a nice hairline scar instead of a thick raised keloid.
That makes total sense.
Yeah.
But the skin's physical structure isn't its only defense mechanism, is it?
No, it has a highly dynamic neurological component.
Yeah.
The autonomic nervous system actively micromanages the skin's appendages. Like, consider the erector pili.
The what?
The erector pili. It's a tiny band of smooth muscle attached to the base of your hair follicles.
Oh, right. So when a sympathetic nerve impulse hits that muscle, like a sudden drop in temperature or, an acute fear response, it contracts, pulling the hair violently upright.
Goosebumps.
Exactly, goosebumps. But I've always wondered, what evolutionary purpose does that serve? Surely making our arm hairs stand up doesn't actually retain that much body heat or make us look that intimidating.
Well, the thermoregulatory aspect is a remnant from when our ancestors had thicker coats, certainly. But the hidden mechanism is what happens at the base of the follicle.
What do you mean?
Because of the exact anatomical angle of the erector pili, when it violently contracts, it physically crushes the adjacent sebaceous gland against the connective tissue.
Oh, wow.
Yeah, that mechanical squeezing forces sebum, oil up and out onto the surface of the skin. So in a stress response, your autonomic nervous system is instantly deploying a layer of waterproofing and antimicrobial oil to the skin's surface.
That is wild. I never knew that's why we get oily when we're stressed.
It's all connected.
So as our scalpel parts that skin, we don't just hit raw muscle. We enter the compartmentalized world of the biological wrapping the fascia.
Yes, starting with the superficial fascia.
Which is that loose areolar connective tissue holding fat and occasionally thin sheets of muscle like the platysma in the neck.
Exactly. But deep to that is the deep fascia. And this layer fundamentally alters how pathology spreads in the body.
I tend to visualize deep fascia as specialized athletic compression gear. Yeah. Tightly wrapping the limbs and holding specific muscle groups in their designated tracks.
It acts exactly like high-grade compression gear, but with severe clinical consequences.
How so?
Because deep fascia forms completely inflexible, fibrous sheaths around muscle groups. And it sends intermuscular septa diving down to attach directly to the bone. It creates closed, sealed compartments.
Right.
So if an artery is severed inside one of those compartments, or if massive inflammation occurs, that fluid has absolutely nowhere to go.
The fascia won't stretch to accommodate it.
It cannot stretch.
Right.
So the pressure inside that compartment builds exponentially until it literally exceeds the patient's arterial pressure.
Oh man, so the blood flow to the muscle is just choked off.
Exactly. The tissue becomes ischemic and it begins to die. That is compartment syndrome.
And that's why a surgeon will sometimes have to slice that deep fascia wide open, right? A fasciotomy.
Yes, just to release the pressure and save the limb. It's brutal, but necessary.
The deep fascia also thickens at the joints too, doesn't it?
Yeah.
At the wrists and ankles, it forms retinacula.
Yeah, those act like biological zip ties. They keep the tendons from bowstringing away from the bone when you flex your joints.
Which leads us perfectly to the other major connective tissues, ligaments and tendons. Ligaments attach bone to bone, and the text classifies them as dense collagen fibers designed to be unstretchable.
Designed to be, yes.
But if they are entirely unstretchable, how do we explain, hypermobile athletes or the mechanics of a severe, prolonged sprain?
That's a great question. We have to differentiate between physiological load and plastic deformation.
Okay, break that down for me.
Under normal, everyday loads, a typical collagen ligament does not have elastic recoil. It isn't a rubber band. Now, the exceptions are true elastic ligaments, like the ligamenta flava in the spine.
Right, those are packed with elastin to help you return to an upright posture after bending over.
Exactly. But standard ligaments are like thick ropes. If you apply a massive traumatic force, say, you roll your ankle violently, you push the collagen past its structural yield point, the fibers suffer microscopic tears and permanently elongate.
So they do not snap back.
They do not.
Well, if a permanently stretched ligament leads to a permanently unstable joint, how does physical therapy actually fix a severe sprain? Are we just trying to convince a ruined ligament to tighten up?
You cannot exercise a ligament back to its original length. It's physically impossible. Physical therapy entirely bypasses the ligament.
Oh, really?
Yeah, you are hypertrophying the muscles and tendons that cross that same joint. You are training the active dynamic stabilizers, the muscles, to compensate for the permanent failure of the passive static stabilizers, the ligaments.
That perfectly frames the relationship between ligaments and tendons, honestly. Tendons are the cables attaching those dynamic muscles to the bones. And the anatomical engineering of tendons, specifically how they're lubricated, is just fascinating.
You're talking about the synovial sheaths.
Yeah. Where tendons cross joints, they are wrapped in synovial sheaths. I always pictured a synovial sheath like a plastic straw perfectly encircling a wire. A closed, liquid-filled cylinder to prevent friction.
A closed cylinder would be a biological dead end, though.
Because it cuts off the blood supply.
Exactly. Tendon tissue is living. It requires constant oxygen and nutrients. If it were perfectly sealed inside a frictionless cylinder, no blood vessels could reach it, and the tissue would necrose and rupture.
The architectural workaround for this is brilliant. Imagine taking a slightly deflated balloon and pushing your fingers straight into the side of it.
I like this analogy.
The balloon wraps around your finger, giving you a double layer of slippery material, a visceral layer touching your finger, and a parietal layer on the outside with fluid between them. But because you pushed in from the side, the balloon doesn't connect perfectly at the back. There's a gap.
And that gap is the biological lifeline. It forms a fold of tissue called a vinculum.
The vinculum.
Right. Through that specific fold, blood vessels dive directly into the tendon to feed a longitudinal anastomosis.
A connected network of blood vessels.
Yes, a continuous network running the entire length of the tendon core. It allows the tendon to glide back and forth like a high-tension cable on a pulley while remaining entirely nourished by the surrounding vascular system.
It's just brilliant design. And following those cables upward brings us to the engines that pull them.
Yeah.
The muscles. The text delineates 3 distinct types of muscle tissue, right?
Yes, smooth, cardiac, and skeletal. And each has cellular mechanisms tailored completely to their function.
Let's start with smooth muscle.
Yeah.
That's in the gut and blood vessels. It's involuntary. But it's the cellular communication that really stands out to me. Smooth muscle cells are connected by gap junctions, or nexuses.
Those are physical protein channels linking the cells together.
Right, allowing electrical impulses to wash over the entire tissue instantly, resulting in this slow, massive, coordinated contraction-like peristalsis pushing food through your intestine.
Exactly. Now, cardiac muscle is also involuntary, but it is structurally striated and heavily interdigitated.
Meaning the cells are woven together.
Yeah, they lock together like complex puzzle pieces to massively increase the surface area for electrical conduction. This makes the heart tissue incredibly fatigue-resistant. I mean, it operates continuously for a century without a pause.
That's mind-blowing when you think about it.
Yeah.
But it's the skeletal muscle, the voluntary engines of the body, where the architectural arrangement drastically alters the physical output. Form really dictates function here.
Oh, absolutely.
Like, if a muscle has parallel fibers running end to end, like the sartorius muscle in the thigh, it can contract over a massive distance, giving the limb a huge range of motion.
But if a patient needs raw, brute power, the architecture changes entirely to a pennate or feather-like arrangement.
Like the subscapularis in the shoulder.
Yeah, or the tibialis anterior in the leg. The muscle fibers come in at an oblique angle to attach to a central tendon. By angling the fibers, the body can pack significantly more individual muscle cells into the exact same volume of space.
So you sacrifice the total distance the muscle can shorten, but you multiply the raw contractile force.
Precisely. It's a mechanical trade-off.
But, brute force is useless without control. What completely shifts the paradigm for me isn't the heavy lifting, it's the internal telemetry, the muscle spindles.
Oh, the proprioception system.
Yeah. I think of the skeletal muscle like a highly advanced smart car. The massive outer extrafusal fibers are the engine block. They burn the fuel and pull the chassis. But buried deep inside the muscle belly are the intrafusal fibers. These are the car's high-speed internal telemetry sensors.
That's a great way to put it. They are encapsulated sensory receptors that run parallel to the main muscle fibers.
So as the main muscle stretches or contracts, the intrafusal fibers stretch with it.
Exactly. And they continuously fire high-velocity data back to the central nervous system, reporting on the exact length and the rate of change in tension.
So your brain doesn't just command a muscle to fire blindly.
No, it receives a microsecond by microsecond data stream confirming exactly what state the engine is in. It allows for the precise coordinated movements required for everything from, threading a needle to performing a surgical incision.
Incredible. And all of those engines are anchored to the physical framework of the body, the bones. The development of that framework happens through two distinct pathways.
Intramembranous and endochondral ossification.
Right. Intramembranous ossification is where bone is laid down directly into fibrous tissue, bypassing any cartilage stage. That's how the flat plates of your skull vault form. But the long bones of the limbs, like the femurs and the humeri, develop through endochondral ossification.
Which is a frequently misunderstood process, honestly.
So,
Well, the pre-existing cartilage model of the bone doesn't just magically transmute into bone tissue. The hyaline cartilage is systematically invaded by blood vessels, destroyed by the body, and subsequently replaced by entirely new bone matrix.
it's a complete tear down and rebuild.
Exactly. And the interior cavity of that bone is highly dynamic over a human lifespan.
Specifically the marrow. In an infant, nearly all bone marrow is red marrow. It's actively performing hemopoiesis, churning out red and white blood cells at a massive rate to support a rapidly growing body.
But as we age, that system downsizes. It's an issue of metabolic efficiency. An adult just doesn't need that massive volume of blood cell production.
So the red marrow begins to atrophy and is replaced by yellow, fatty marrow.
Yeah, and this transition moves from the distal parts of the body, the hands and feet, and marches proximally. By early adulthood, active, highly vascular red marrow is largely confined to the axial skeleton,
So the skull, ribs, sternum, vertebrae.
and just the very top ends of the femur and humerus.
And this physiological shift has a devastating clinical correlation, unfortunately. If an adult patient develops a cancer that metastasizes to the bones, those specific pockets of active, nutrient-rich red marrow are exactly where the malignant cells will seek refuge and multiply.
Sadly, yes. It is prime real estate for metastases. But children face a different, highly specific vulnerability in their bones regarding blood supply, osteomyelitis, or severe bone infection.
Because their bones are still growing.
Exactly. In a growing child, the long shaft of the bone, the diaphysis, is separated from the end cap of the bone, the epiphysis, by a thick cartilaginous growth plate. The blood vessels supplying the shaft, the terminal branches of the nutrient artery travel right up to that growth plate and form hairpin loops.
They're end arteries.
Right. They do not cross the cartilage, and they do not connect with the vessels on the other side.
So if a child has like a minor scrape that introduces bacteria into their bloodstream, those bacteria travel through the circulation until they hit those hairpin loops at the growth plate. Because the artery just loops back on itself without branching, the blood flow hits a literal dead end and severely decelerates. It sludges.
And when the blood flow sludges, the bacteria drop out of suspension and settle directly into the bone tissue. They thrive in that stagnant environment, causing a massive infection in the metaphysis.
But once that child reaches adulthood and the cartilaginous growth plate finally turns to bone and fuses,
Vascular channels open up. Anastomosis form across the entire region, the end arteries disappear, the blood no longer sludges, and that highly specific vulnerability to infection just vanishes.
it fundamentally proves that a bone is not a piece of dead, static scaffolding. It is aggressively alive. I mean, the internal lattice of spongy bone, the cancellous bone trabeculae, will literally break themselves down and rebuild in a completely different physical alignment just to adapt to a new directional stress.
Like a patient taking up a new sport or altering their gait after an injury, it's a continuous, lifelong cycle of osteoclasts tearing down old bone matrix and osteoblasts laying down new reinforcement.
Which brings us to where those dynamic bones meet. The articulations or joints, the pivot points.
Right, and the text categorizes them strictly.
Fibrous joints, like the sutures locking the skull plates together, offer negligible movement. Cartilaginous joints come in two forms. Primary synchondroses, where bone meets hyaline cartilage like the growth plates we just discussed.
And secondary symphyses, where fibrocartilage unites bones in the midline of the body, like the intervertebral discs of your spine.
But the clinical heavyweights are the synovial joints, the highly mobile hubs of the limbs, and their mechanical stability is entirely dependent on their spatial positioning. This is the concept of close-packed versus loose-packed positions.
A very important concept. When a joint, like the knee, is fully extended into its close-packed position, the articulating surfaces of the bones are at their absolute maximum contact.
The surrounding joint capsule is twisted taut, and the ligaments are pulled to their maximum tension. the joint is locked into its most stable configuration.
Right. So if a massive traumatic force is applied to a patient's leg while the knee is fully close packed and locked, what gives way?
The bone.
Exactly. Because there is absolutely no slack in the ligaments or the capsule to absorb the kinetic energy, the force is transferred directly into the solid structure. The bone shatters. You see catastrophic structural fractures.
But conversely, if the joint is flexed in a loose packed position, the bones are less congruent and the capsule has slack.
So a trauma in this position is much more likely to bypass the bone and rip the ligaments or cause the joint to dislocate entirely because the structure has enough mechanical play to separate.
And when those traumas arrive in the emergency department, the medical team has to communicate the complex anatomy of the injury instantly. This is why medical eponyms, naming structures or conditions after the physicians who first mapped them, refuse to die out.
Modern anatomical nomenclature really strives for purely descriptive Latin terms to ensure global accuracy. But eponyms survive because they are the ultimate clinical shorthand.
Right.
When every second counts, you don't describe the precise angle and displacement of a distal radius fracture. You shout, "Collis fracture," and every physician in the room instantly visualizes the exact backward displacement of the wrist and knows the required reduction technique.
It's the same with Charcot's artery of cerebral hemorrhage, or the tetralogy of Fallot for congenital heart defects, or Horner syndrome.
Oh, Horner's is a classic.
Yeah, if you say Horner syndrome, no one has to explain the underlying cervical sympathetic nerve damage causing the drooping eyelid, the constricted pupil, and the lack of sweating on one side of the face. The name carries the entire diagnostic weight.
They are narrative anchors that tie dense anatomical theory directly to the living patient in front of you.
Which is exactly where we need to finish this deep dive, applying the theory to a living patient. So listeners, imagine you are the practitioner on shift in the ER tonight. The paramedics wheel in a patient who was caught in a flash fire. You need to calculate their fluid resuscitation instantly.
A rapid visual assessment shows severe burns covering their entire right arm, as well as the entire front of their chest and abdomen.
If you know the rule of nines we discussed earlier, you already have the math.
Right. The entire upper limb is 9%. The entire anterior torso is 18%.
So 9 plus 18 gives you 27% of the total body surface area compromised.
In 3 seconds, you have the exact physiological metric required to order the life-saving saline drip. You have bridged the gap from textbook theory to clinical survival.
And while those algorithms and anatomical rules give us the power to save lives, I think it's crucial to remember that the human body isn't a completely solved equation.
It certainly isn't. Consider the sesamoid bones.
Oh, yeah?
These are bones that grow entirely within a tendon to alter the mechanical line of pull and reduce friction. The patella, or kneecap, is the largest example. It serves a vital, undeniable mechanical purpose. But some patients possess extra, highly variable sesamoid bones that seem entirely functionally useless.
Like the fibula.
Exactly. The fibula is a tiny bone that occasionally forms in the lateral head of the gastrocnemius muscle in the calf. It doesn't act as a pulley, it doesn't protect the tendon from a hard underlying bone, it simply exists buried in the tissue.
So are these seemingly random extra bones evolutionary ghosts left over from an ancient mammalian ancestor? Or do they play some incredibly subtle microscopic biomechanical role in gait that our current imaging and physics models simply haven't mapped yet?
It's a great question. We just don't know yet.
It is the perfect reminder that no matter how detailed the textbook gets, the human machine is still a living, breathing, evolving mystery. The map is not the territory. Keep exploring it. Catch you on the next deep dive.